in most individuals. Or you could have a really high total cholesterol because the LDL is bad, and that would be bad. So the total cholesterol doesn't give you very much information in an individual patient. In populations of patients, it can be used to differentiate people at relatively lower risk and relatively higher risk. But in an individual patient, it doesn't differentiate sufficiently to tell whether the cholesterol issue is mostly good, mostly bad, or mostly neutral, if you will. When I say triglycerides are neutral, it's a little bit controversial. If we look at all the other risk factors and then either add a high triglyceride or a normal triglyceride, the people with the high triglyceride probably have a little bit of extra risk, but the number is relatively small. And the reason for that is that most people who have high blood triglycerides have it not as a primary genetic disorder, but as a result of something else that's gone amok. And those other things that have gone amok can be captured elsewhere in the equations. For example, the most common causes of high triglyceride is an elevated blood sugar. So people with prediabetes and certainly diabetes that's not well controlled will have a high triglyceride. Alcohol use can raise your triglycerides. Estrogen use, either as a contraceptive or hormone therapy, can raise your triglycerides. And then there are some other diseases like low thyroid, what's called nephrotic syndrome, a type of kidney disease that can do so as well. And then there are also genetic disorders which cause high triglycerides. But if triglyceride was a really bad actor for heart disease and stroke, then one would expect that the individuals that have super high triglycerides because of genetic disorders, and I mean really high, if normal is less than 150, there are people with 10,000. And you would expect those people to be dropping dead like flies, and they don't. And so we don't think that triglyceride per se, in and of itself, is a major factor in whether we're going to treat someone's cholesterol or not. We focus primarily on the LDL and HDL in our thought process. But like I said, we do put in the total cholesterol in our equations to predict risk. And as I'm showing here, total cholesterol does reflect a high triglyceride. Now, there's also other conditions. If your triglyceride is very high, we do recommend treating that to prevent inflammation of the pancreas, what we call pancreatitis. Separate disease, separate medicines, separate conversation, not to be confused with treatment of lipids to prevent heart disease and stroke. And then you'll see on some of the slides HSCRP, that stands for highly sensitive C-reactive protein. That's a measure of inflammation. As you probably have heard over the years, one of the hypotheses related to heart disease and stroke has been that it's an inflammatory condition. This is a controversial area. There are believers and non-believers. And we'll talk about the highly sensitive CRP towards the end of the talk. We don't use it very much as an initial approach, but that could change with new science. It does increase your risk by some amount, but our current guidelines do not recommend doing it routinely, but rather saving it for a tiebreaker when we need a little bit more information in a close call. I'll also include some organizations, and actually one disease and some organizations on some of the slides. So CHD stands for coronary heart disease. It also is known as coronary artery disease, or CAD. And that refers to heart attacks.